Foundation for Children's Health. Let me do a few housekeeping things before we start. Given the large number of people who are attending, we will take questions through the chat box, which is on the side of your screen. All attendees will be muted for the duration of the webinar, but we will be posting the slides and a recording of the webcast on the Foundation website shortly after the presentation. I'd like to begin, if I could, with a quick question for those of you who are listening in, just to give us a baseline of where your understanding of the topic is now. So if you could post that, Danielle, and I'll just give people 20 seconds to answer this. How well do you understand the issue of coordinating care for children with social complexity? Thank you. So let me introduce our speakers for today. Michael Harris is Professor and Chief of Pediatric Psychology in the Child Development and Rehabilitation Center at the Oregon Health and Science University. He has developed an innovative program for providing very comprehensive services to patients with chronic illness and coexisting social complexity. Professor Rita Mangione-Smith is Professor and Chief of the Division of General Pediatrics at the University of Washington Department of Pediatrics and is a nationally known health services researcher. So let me turn this over to Dr. Harris. Michael?
Thank you. So I'm going to be talking about a program called Niche, Novel Interventions in Children's Healthcare, which, as Dr. Shore said, addresses youth with both medical and social vulnerability and complexity. Next slide. So treatment as usual in most medical centers is we give a lot of what, a little bit of how, and not a lot of why. So we provide a lot of information and resources when people come into the hospital repeatedly for avoidable hospitalizations. Next slide, please. So what Niche is just the opposite, is we want to identify the why. We're less interested in the what. So we're looking at the social ecology, the context in which people are embedded. We believe those are the true drivers to what brings these young people back into our hospitals repeatedly. Next slide. So when we're looking at who is what we would call niche worthy for our program, we look at the intersection between medical vulnerability and social vulnerability. All the kids we see have either medical complexity, a chronic health condition, or special health care needs. And then those in particular that are very young, are high cost, have other comorbidities, as well as teenagers. And then the social vulnerability side is all the variables we see as impacting their ability to successfully manage their health, which include ethnic minorities, immigrants, low education, non-English speaking families, lack of support, insecure housing, as well as many other variables. Next slide, please. So the niche model is three-pronged. It's delivered by one person. We call them an interventionist. It's 24/7 access. We believe that that's a critical piece for this population, that these people have access to us in the moment so we can solve problems, address issues as they're happening, which we believe are the drivers that would bring them into the hospital or what leads to a deterioration in the child's health. We work in the homes, we work in the communities, in the schools. We work with other agencies like juvenile justice, child protection. We address issues of food insecurity, housing insecurity. And then we also integrate with the healthcare system where we attend clinic visits. We are a liaison with the healthcare team. We provide any support around the child's health. Next slide. Our delivery of care, as I said, is 24/7. We're where patients and families exist. So inpatient in the clinics, we use technology to interact with our families. This is obviously the primary way that families these days interact, and so we leverage technology, whether it's video conferencing or texting or even just calling on the phone. Or in the schools, we attend social service agency meetings, we work with employers, whatever it takes. Next slide, please. So the sample I'm going to be talking about today, we've seen in the past 5 years through niche about 160 families. This is data from 105 of our families. You can see the breakdown in terms of our demographics. The majority of our referrals are teenagers, but we do see a number of NICU grads as well as younger children. Most of the patients we see are Medicaid. That's where the program originally started as an effort to bend the cost curve in our Medicaid population. Equal numbers basically of female and male. Because we're in the Pacific Northwest and specifically in Oregon, we have a disproportionate number of Caucasian families, but we do have many non-English speaking families as well. Next slide, please. So in terms of medical vulnerability, we see pretty much any child who comes into the hospital repeatedly for a medical issue. This is not for mental health or behavioral health issues. They may have comorbidity around those issues, but our focus is largely on young people with, like I said, medical complexity, chronic health conditions, and special health care needs. We see kids with chronic pain, cystic fibrosis, end-stage renal disease, failure to thrive, inflammatory bowel disease, seizure disorder. We see a number of transplant patients. Next slide, please. So when we look at our data on medical complexity, and we may define this differently, I guess the better term would be medical vulnerability. Number of our patients have either one or two body organ systems impacted by their medical condition, and less so for 3 to 4 or greater than 5. Our tech-reliant patients are increasing in numbers. We're close to 20%, and that's growing. And then in terms of the demands, we evaluate the demands of the regimen on patients, and we have a algorithm to determine where they lie. But they're pretty equally distributed in terms of 1 to 2 hours a day with little need for little supervision and oversight by a parent, and with minimal impact on daily living. 1 to 2 hours a day plus, that would mean impact on daily living, and then 1 to 2 hours plus, which would be impact on daily living plus need for pretty significant oversight. And then 2 to 3 hours a day with impact on living and need for oversight, and then 4+ hours a day, obviously, with both. Next, please. So if you look at our social complexity, which is what this conversation is about, we have a measure, I believe it's posted for webinar participants to take a look at. This was a measure that we developed from a lot of different measures that really was focused on our population in particular. But you can see that of the 105 youth and families who are participating, we have a very socially complex group of patients that we see. A lot of our kids are not in school or frequently truant. A lot of them have either CPS or DHS involvement. Many of them are currently involved with CPS or DHS. They typically don't know what to do with these patients. Medical foster homes are few and far between and really are not well suited for this population. A lot of food insecurity, families who live in food deserts and can't access fresh foods and healthier food options unless they ride a bus for 2 hours. Unreliable or no transportation at all. And then limited support from families and friends is quite high. Families who are isolated they don't have a religious community, they don't have close friends available, and they don't have family available that can support them when they are in need of help when they're managing their child's health. A lot of insecure housing. Many of these families are on the verge of eviction or have been evicted and live on the streets and live in shelters and live in hotels. Single parenthood is moderately high, but you know, a lot of these folks have parents who are in relationships, so we don't consider them necessarily single parented. And then a number of our patients come from a distance to the hospital center, so living remotely from a tertiary care center appears to be a pretty significant thing across the board for all these youth. Next, please. And when you look at the parents' medical and mental health status, this information, by the way, is all derived directly from the interventionists who work directly with these families. So this is firsthand knowledge. Most of this isn't contained in the medical record or the EMR, and so this is from interacting with patients and families for a month or so before they're able to get all this accurate information. But high rates of drug and alcohol use in parents, high rates of mental health issues. Parents with medical conditions, 40% of our population have some significant chronic health condition. A lot of domestic violence. Parent with a criminal history, our data is really based on whether a parent's in prison or in jail, not whether they've have any kind of record of criminal history. And then death of a parent. We look at kind of an ACEs approach of child trauma. We have a significant amount of that, as well as children receiving or needing mental health services. Next, please. So when you look at our outcomes, we target the outcomes of the triple aim, which is improving health, improving care, and decreasing cost. If you look just at improving health, these are 3 patients with failure to thrive and their ZBMI scores 365 days prior to their initiation of niche services, and then close to 365 days for at least 1 or 2 of them after niche services were initiated. And you can see for all 3 patients, their ZBMIs rose after involvement in our service. Next. This is just one patient's data who has CF. You can see FEVs, FEV1 data, and each of those spikes represents a clean out, so a hospitalization for a clean out, and so you can see that their FEVs went up substantially after the clean out, but then immediately dropped down, and then the trajectory of reduction in FEV1s continues to decrease, and this is over a 5-year period. It looks like 4-year period, 2012 to 2016. The blue bar represents our initiation of services. So for a year we were involved with this patient and basically held FEVs stable, and then as soon as the young person was discharged from our service, had a decrease in FEVs pretty significantly down to 60%. Next, please. This is our data from our type 1 patients who have type 1 diabetes, and for all our cases, looks like we have more than a 1% decrease in A1C, which is translates to about $2,000 annual savings in diabetes care. Our prevention cases equally had a bigger reduction of 1%, and our prevention cases are basically kids who've been identified as having a lot of psychosocial complexity and risk factors, but who have yet to be identified as high utilizers or young people who come back to our hospital unnecessarily. And then our intervention cases, another large decrease, and these are kids who've already evidenced a high spend because of repeat diabetic ketoacidosis. Next slide. So if you look at our reduction in costs, that was our reduction in our improvement in care or in health. If you look at our reduction in costs, this is per member per month spending on our cases that we feel like we can adequately reduce the spend. The year prior for the population that was assessed in this particular slide was averaging over $1,500 per member per month. So that's a significant spend in a year, well over close to $20,000 if not more, and then the year during our care dropped down to just $12,000 per member per month. And then if you look at our data further out after they've been discharged, it continues to drop down even lower. Next slide, please. So once again, more expected cost reductions in our population. These are expected cost reduction cases that are highly socially complex, but we're really just stabilizing their health. We're not as interested in reducing the spend. And even in this population, we basically want to keep them alive. we've been able to reduce the spend significantly from over $4,000 per member per month down to about $1,500 per member per month during our care. Next slide, please. We do have expected cost increase cases. When we look at cost reduction is not necessarily a good thing in healthcare. And so in these are particularly transplant cases where kids have not been put on transplant lists, they've not been listed and because of their poor adherence. And so when we come in or they're not getting regular dialysis, we come in, we get them back on dialysis, we get them back on a transplant list, and then they are eventually transplanted, which obviously results in an increase in the spend. But once again, saves a child's life, and that's a good thing ultimately. So the cost increase in this particular case is a positive outcome for this population. Next slide, please. Once again, more of our trying to stabilize our patients' lives per member per month. These are very high spend patients as well as very socially complex patients. So they're both spending at a very high rate, $14,000 per member per month spend, which is well over $100,000 a year. And we're bringing that down below $4,000 during our care. Next slide, please. When you look at improving care, so that's the third of the triple aim, we're showing a reduction in hospital day stays. This is not just an improvement in care, but it's also an improvement in cost because hospital day stays tend to be the thing that drives most of the avoidable costs in this population. It's not necessarily ED visits. So prior to niche, our population is averaging over 20 days in the hospital per year, and then during their care, it's dropped down to around 7, and then after their discharge, it's around 3. Now, this shouldn't be 0 because all these kids need to be in the hospital for a variety of reasons. Our agenda is not to do away with hospital care, it's to do away with avoidable hospital care. Next slide, please. Likewise, we see a reduction in ED visits. So if you compare our data with the Oregon CCO data, granted this is somewhat apples and oranges because the Oregon CCO data is mostly adult data, but in the Healthcare Transformation Report for Oregon CCOs, they evidenced a reduction of ED visits in the total Oregon population that was enrolled in CCOs of 17%. We had a reduction of over 20%. If you look at the reduction in hospitalizations in the Oregon CCOs, it's about 27%, and we evidenced a 50% reduction in hospitalizations. And then the Oregon report does not report on hospital day stays, but we did, and we had a 73% reduction in hospital day stays for our population. Next slide, please. And then we have a measure of care, and the care measure is this is just the provider report. We actually also have patients fill out this and family members fill out this. And across the board, if you look at some of the items in our reports of improved care, there's better communication. Families are more engaged and in care. They have better adherence to treatment. They're showing at more appointments. Caregivers are more involved in the care. Next slide. And then perceptions of healthcare providers have changed around the families. They feel more effective in delivering care to these families. There's less conflict with the medical team, improved care coordination, and family appears to have better access to resources. Next slide, please. So the next steps with regards to social complexity, we want to look at the number and type of social complexity variables as they relate to health outcomes. We don't have enough data yet to do that, but if we look just at our type 1 population, which is our biggest population, the number tends to hover around 6 to 7 social complexity variables that really drive the health outcomes. Once you get above 6, then it's really clearly linked. We also want to look at the number and type of social complexity and utilization and cost. We haven't done that either, but when we get more data, we'll start looking at that. We want to look within conditions, so we have a subpopulation of kids who are transplant cases, kids who are failure to thrive, type 1, inflammatory bowel disease, CF, cancer, And so we want to look within conditions and see if conditions drive some of these social complexity and health outcome relationships. We want to look at weighting of individual social complexity factors. Once again, we'll need a much larger sample to do that. And then ultimately, we want to look at a predictive risk model so that we can predict outcome. And then when people come into our medical center or any other medical center for that matter, we can more successfully predict what their utilization patterns will be based on that model. Next slide, please. So I want to thank everybody for listening in, and I'll field any questions at this point.
Michael, thank you. That was terrific. I'm sure questions will start flowing in. I just want to remind people that Michael has generously shared his screening instrument, which is on our website, and that along with the presentation and slides is going to be available for download. Couple questions. First one, Michael, does the cost in your slides represent charges or does it represent total medical expenses?
So the cost in our slides comes from our payers, and our payers present with both payments made as well as, charges as well as payments. All that cost data is largely charges, and so if you look at what we get paid in Medicaid, it's about 25 cents on the dollar, which really, I'm glad you brought that up, Dr. Shore, because it really suggests that the institution itself has some skin in the game here in terms of we get a fraction of what we charge for these patients. They tend to be low acuity patients filling up a bed, and you know, if the more they sit in our hospital, we have like a DRG, a cutoff at some point, so they could be in the hospital for 3 days or a month, and we get paid the same amount of money. And so there's shared risk here. That's not just the hospital that's taking a hit in terms of the cost, but it's also the payer.
Michael, can you explain how you're funded?
Sure. So initially this was funded through a CSSI innovation grant from one of our CCOs, and since that time we've established contracts with not just CCOs but commercial payers to pay a case rate. So it's a bundled rate per patient, and it's inclusive of all our costs.
Okay. Let's see. Can you talk about your actual interventions?
Sure.
What does your team really?
So the actual boots on the ground interventions vary wildly from really specific kinds of problem solving, communication skills training, role stratification, so more very behaviorally based, skills-based interventions for families, not just interacting with each other, but with social service, with schools, with healthcare team. Other interventions are what a lot of people would consider care coordination interventions that involve integration with the healthcare team and getting people access to what they need, whether it's getting them to an appointment or getting services, getting medicines. And then the third prong is what people traditionally would think of as case management, and that's dealing with what a lot of people think of as background noise that really gets in the way for these families of managing a child's health, and that would be things like food insecurity, housing insecurity. So we work with our agencies that provide housing, we work with agencies that provide food, whatever the family needs. So we're really addressing what I would consider as the social determinants of health that drive a deterioration in the children's health.
Michael, what's the background of these people, and do you do any special training?
So our mantra is that we hire for attitude and train for skill. Most of the people are master's prepared, but we prefer people from varied backgrounds. We really like people who have the 10,000-foot view of human behavior. So People who think in patient-centric ways are not necessarily good at this. We have one individual has a master's in international not-for-profit and has worked in Nepal and Afghanistan, understands complex systems, understands politics, understands people who have a lot of challenges in front of them. Other folks who are on our team who provide this care have masters in public health. We really find them to be quite good at this. So it really varies in terms of background.
What's their caseload?
So the caseload is consistent with any intensive caseload. If you look across the board at intensive home-based behavioral health interventions for people who are severely mentally ill or any other population, it hovers between 7 and 8 per interventionist. But that is consistent with any other intensive program. One thing I want to say a little bit about, just really quickly about this, is that one thing that's kind of frustrating for me as a pediatric psychologist is that when you think of medical complexity, we provide the highest level of medical care to that population, but when you think of social complexity, we tend to start with the lowest common denominator. We go with a phone call from a behavioral health specialist, or we look for a community mental health worker to help out, or a home health nurse to visit once a month. So this particular population, I think, needs everything that we provide on the medical end, we need to provide on the psychosocial end.
We have time for one more question, I think, although there's a ton of good ones here. A couple people have asked, how do you handle the 24/7 staffing issues?
So we have a team of about 10 interventionists, and then there's 2 clinical supervisors plus myself. We are on 24/7 for our interventionists. They cross-cover each other. But we also, as a part of, this is a skills training kind of effort for families. We don't want to take over their families. We want to build skills so that we can get out of cases. So we have interventionists schedule time off from families and specifically tell them, I'm going to be gone for the weekend, and I want you to just do all the things we've talked about. There's some benefits to being on 24/7 for this population because it allows some flexibility for our interventionists, but also we do a lot of proactive reaching out. We do less reactive. So the 24/7 sounds like it's a lot, but as long as we're proactively reaching out to these families, we nip problems before they become problems, and so that's the way we manage it.
Terrific. That's wonderful. We'll have to move on. Let me just do a quick 30-second or so audience poll here. We have 2 questions we'd like people to answer. First was Professor Harris's presentation, did it increase your understanding of care coordination for social complexity? And the next question, has this moved you to think about how to support improvements in coordinating care for children with social complexity in your own work? Terrific. So let's move on now to the presentation by Dr. Rita Mangione-Smith, who's going to talk about managing social complexity and identifying social complexity from more of a research perspective.
Thank you, Ed. So yes, what I'm going to present to you is work that's been done by the Center of Excellence on Quality of Care Measures for Children with Complex Needs. That is an Agency for Healthcare Research and Quality and Center for Medicare and Medicaid Services funded center. and it involves a multi-stakeholder consortium of organizations. So just want to be clear that what I'm presenting to you is not just my work, but the work of many. So next slide, please. So why do we need to assess risk and have tiered care? Well, I think Michael gave us a great example of what we're seeing across the country, which is a current focus on the triple aim, but particularly on cost containment, really trying to produce what's being referred to as high value care. And when we think of value, that's really the equation of quality over cost. So while we're trying to enhance quality, we're trying to either hold costs steady or decrease them. Many states, though, when they think about these children, have limited resources to address the problems that they face if they are medically complex and or socially complex. So it begs the question, how do we allocate those limited resources? And this is something that I think a lot of states and organizations are struggling with. Do we base it on numbers of diagnoses, patterns of utilization, social context in which the children live, a combination of those things, or something else altogether? So next slide, please. So as we start to think about and struggle with that question, one of the first steps our center decided that we needed to take was to define social complexity. And one potential definition, and this is a definition that went through several iterations within our center membership, is that it's a set of co-occurring individual, family, or community characteristics that can have a direct impact on health outcomes or an indirect impact by affecting a child's access to care and or a family's ability to engage in recommended medical and mental health treatment. So next slide, please. So using that definition, our center set out to do 2 studies to try to develop ways to identify these children. Now, Michael talked about their screening tool, and in a clinical setting or a setting where you have interventionists, you can do survey-based or interview-based collection of risk factors. But what the states were looking for within the context of what our center was doing was a way to begin to identify these children more at a population level. So this is what these 2 studies were about. We conducted them in 2 different states. The first was in Washington, and the second one was in Minnesota. And we were trying to answer the question, can we validly identify children with social complexity using state administrative databases? So in the Washington study, we asked which social complexity risk factors can we identify using their data. And do children with these risk factors have increased ED utilization? And why did we want to look at that? We really felt ED utilization was a potential marker for poor access to care in a primary care medical home. In the Minnesota study, we asked the same question, which risk factors can we identify in their state data? And then, importantly, are they concordant with caregiver reports of social complexity? So we wanted to see if you interviewed a parent who had a child that was identified as having these risk factors in administrative data, would that parent in fact endorse having those risk factors? And then, does social complexity predict caregiver-reported need for care coordination? If we're going to allocate resources to these children, are these families that actually endorse having a need for that? Next slide, please. So I'm going to do a little bit of a deep dive first into the Washington Medicaid study. But to start out, for both studies, we started looking at the scientific literature and did a literature review to identify social complexity risk factors that in previous studies had been associated with poor outcomes. And by that I mean increased ED utilization, increased ambulatory care sensitive hospitalizations, so those avoidable hospitalizations that Michael was referring to. Decreased well child care visit adherence, decreased frequency of being fully vaccinated, and decreased continuity of care. So how often do you see the same provider or team of providers when you access care? Next slide, please. So from that literature review, we identified 12 social complexity risk factors that were related to one or more of those outcomes. And those included the list here that you can see: parent domestic violence, mental illness or physical disability, child abuse and neglect, poverty, low English proficiency or having a foreign-born parent, low educational attainment for the parent, adolescents who had been exposed to intimate partner violence, parent substance abuse, discontinuous insurance coverage for the child, and being involved in the foster care system. So many of the risk factors that you heard from Michael. Next. Our working group within the center, although we did not find the following risk factors in the literature review, they hypothesized that these 6 additional risk factors would likely also be associated with worse outcomes. And those included parent death, parent criminal justice involvement, homelessness, child mental illness, substance abuse, or child criminal justice involvement. Next slide, please. So what we did is we went to the Washington Department of Social and Health Services integrated database. We had our collaborators at Washington State, and they have this unique database that they've put together that includes their medical claims and encounter data, their payment and service records, and arrest records within the state. Within that database, there are records for children that are linked to their biological parents. And in the case of our study, 83% of children in the database, or slightly over 500,000 children, had 1 or 2 biological parents in the database, and that's the group that made up our study sample. Next slide, please. So when we looked into that database, what were we able to find in terms of those 18 social complexity risk factors? Remember, there were 12 from the literature review and 6 additional ones that our working group hypothesized. We were able to find 13 of them, and they're the following ones. So parent domestic violence, mental illness, child mental illness, child abuse and neglect, which was flagged through child welfare system involvement in the state of Washington, severe poverty, which was defined as being TANF eligible, low English proficiency or being a foreign-born parent, homelessness, foster care, parent death, parent criminal justice involvement, child criminal justice involvement, and child substance abuse. The ones that I've put an asterisk next to were not included in our analyses because of collinearity with other variables listed here. So being a foreign-born parent was very tightly collinear with having low English proficiency, so we chose to use the low English proficiency variable. And foster care involvement was very obviously tightly collinear with child welfare system involvement, so again, we chose to use the child welfare system involvement because it was a broader variable. Next slide, please. So we asked the question, are these risk factors associated with increased ED utilization? Now, we really wanted to understand the independent effect of having a social complexity risk factor on ED utilization. So the first thing we needed to do was control for medical complexity, because clearly that also drives utilization. We used the pediatric medical complexity algorithm, which is an algorithm that is applied to medical claims data and looks at utilization patterns and numbers of body systems involved based on diagnosis. And it buckets children into 3 categories: those with complex chronic disease, so 2 or more body systems involved and significant amounts of utilization; non-complex chronic disease, so just 1 body system involved but still with significant utilization; and those children with no chronic disease. We also controlled for child gender, age, race, and ethnicity in our analysis. Next slide, please. So looking first at the medical complexity in our Washington state population, we divided the children into those less than 5 years old and those 5 to 17 years old. And you can see, not surprisingly, the majority of children in the state, around 80% across the whole population, have no chronic conditions. Around 10 to 15% have a single chronic condition, and many fewer, just 5%, have complex chronic conditions. Next slide, please. So what about social complexity? So again, looking at the 11 variables that we were able to identify in the database, we see that there is a fair amount of risk in these populations. So highlighting in green, mental illness in the parent, we found in 1/3 of those in the database. criminal justice involvement in 40%, keeping in mind that this is any record of an arrest. It does not necessarily mean jail time. In families, child welfare system involvement in a third of the population, severe poverty in over 20% of the population being TANF eligible, and low English proficiency in around 20-25% of the population. Among children, mental illness was also quite prevalent in our 5 to 17-year-old group at 18%. Next slide, please. If we looked at numbers of social complexity risk factors, we see that about 50% of our population had 2 or more risk factors. 20% had none. And again, this was striking that it was as many as this when you're looking at the population level. Next slide, please. Now, what about the relationship to emergency department utilization? What we found is among those 11 risk factors, 9 of them were associated with a significantly increased odds of having an emergency department visit during the last year. You'll look at those odds ratios and they don't look very large, but keep in mind we had a very huge population and we only accepted a P of less than 0.0001 as being statistically significant. So these are significant increases in the odds of an emergency department visit. Next slide, please. We then wanted to understand, is there an additive effect? So if you have more of those social complexity risk factors, are you more at higher risk for having an ED visit? And we found really a dose-response relationship here. You can see on the left-hand column as the number of risk factors increases. You look at the middle, your risk steadily goes up with each additional risk factor. Next slide, please. So what did we conclude from our Washington study? That there were 9 risk factors identified in state data that were associated with increased ED utilization, and that may indicate poor access to outpatient primary care and a need for care coordination. And this, again, was controlling for medical complexity. So this was the independent effect of these, or the independent association, I should say, of these social complexity risk factors. And they're listed here. Next slide, please. We also concluded that the association of these risk factors with ED utilization follows a dose-response pattern. So as the number of risk factors for a child increases, their number of ED visits also increases. Next slide. Now I'm going to move us on to the Minnesota Medicaid study, which has some similarities but also some differences. In this study, we wanted to determine which social complexity risk factors could be identified in a different state database, because if any of those of you who have worked within Medicaid know that when you've looked at one state database, you've looked at one state database. And we really wanted to understand how they would differ. We also wanted to determine concordance between administrative data determined social complexity risk factors and caregiver reports of those risk factors. And finally, we wanted to assess whether the presence of those risk factors predicted parent or caregiver reported need for care coordination services. Next slide, please. So when we looked at that same set of 18 risk factors from the Washington study, we found 8 of them in the Minnesota data. The ones that were found in both databases included severe poverty, child welfare system involvement, parent mental illness, low English proficiency, and homelessness. We also found in the Minnesota database, but were not able to identify in the Washington database, parent substance abuse, parent physical disability, and discontinuous, marker for discontinuous child insurance coverage. Next slide, please. So this study involved a much smaller population, only 460 child biological parent dyads. And why was it so much smaller? We started out with a much larger population, but we needed parents to have a phone number that was working, that the Medicaid agency had. They had to pick up the phone, and they had to be willing to do a survey with us. So this is keep in mind, please, this is a much more biased population than the Washington study. It is not a population-based study, but a subsample, and a very, I would say, probably biased subsample because of the need to do a telephone survey. So all children in this particular study had a non-complex chronic disease according to the pediatric medical complexity algorithm, so something like asthma, epilepsy, or diabetes, just a chronic disease involving a single body system. Why did we want them to have be in this particular category? Our center working group hypothesized that we know that children with medical complexity need care coordination, but what we wanted to understand was, if you have a single condition like asthma, do you necessarily need care coordination, especially if resources are limited and we're trying to figure out how to allocate them to different children? They felt that if you had asthma plus you had social risk, you probably did need care coordination just as much as a child with medical complexity. I mean, I think Michael's presentation really supports that theory. So we assessed, so what we did is we assessed risk factors in two ways, as I mentioned, in Minnesota Administrative Data and Parent Survey Report. Again, we were trying to look for convergent validity. So if the administrative data tells us you have this risk factor, how likely is your family to endorse that you have this risk factor? Next slide. So if we look at the risk factor profile here, it's very different than what we saw in Washington State. Again, keep in mind, much smaller population, biased population in that they had to be willing to do a survey. So we see much lower rates of the social complexity risk factors, the most common one being severe poverty in 53% of the population. And here it meant that they were at less than or equal to the 50% of the federal poverty level rather than being TANF eligible. Next slide, please. In terms of numbers of risk factors, again, quite different than what we saw in the population-based study. 30% instead of 20% had no risk factors, and only a third had 2 or more compared to 50% in the Washington study. Next slide. Now, if we look at concordance between the two databases, the administrative data and the parent survey data, there were 3 variables we were not able to look at: substance abuse, child welfare involvement, and severe poverty. Those were not asked in the survey. As I mentioned, we were a multi-stakeholder center, and we have a family advisory panel as part of our center, and our family advisors did not feel it was appropriate for telephone interviewers who were not familiar with the family to be asking about sensitive topics like substance abuse, child welfare involvement, or severe poverty. So those were not asked in our survey. But what we did ask about, we asked the SF-12 instrument, which looks at functional status for adults for mental health functioning and physical health functioning. And we did find very high correlation between mental illness or physical disability being identified in administrative data and parents endorsing they had activity limitation due to either a mental health or a physical health problem. When we looked at homelessness, that was also highly correlated with parents answering that they had 1 or more nights on the street in the last 12 months. Limited English proficiency was highly correlated with parents reporting that they did not speak English, they spoke English not well or not at all. And I will mention that the survey was administered both in English and in Spanish, but not in other languages. And in terms of insurance gap, if we found in the administrative data that there was a report that there was an insurance gap of greater than 3 months for the child, that was also highly correlated with parent reports of insurance gap. Next slide, please. So those were reassuring findings in that what we were finding in the administrative data where we could ask was highly correlated with what we were finding in parent reports. So our next question was, does social complexity predict parent-reported need for care coordination? And in fact, we found that if they had any of those 8 risk factors, according to the administrative data, they had a significantly increased odds of reporting a need for care coordination. When we adjusted for other factors, age, gender, and race, ethnicity, the relationship was still there. We saw an increased odds, but it was no longer statistically significant. We just barely lost our significance. This may have to do with the small size of our sample of only 460. However, we can't really make conclusions about that. This would have to be done on a larger population to verify that it truly is no longer significant. We did see a very strong relationship between being a non-Hispanic Black caregiver and reporting a need for care coordination independent of the risk factor profile. Next slide, please. So what have we concluded from our work? As we think about tiered care, I would say we need to keep in mind that even children with a single social complexity risk factor are at risk for worse outcomes or increased reported need for care coordination. And given our limited resources, we need to focus on children with multiple social complexity risk factors, much like Michael's group is doing with both social and medical complexity. I would say all of the above. Even children with one medical condition plus social risk are ones that I think we should be targeting to some degree. Next slide, please. So what can we do about social complexity? So care coordination, in our experience here, can help with access to care and services for children and their caregivers. It certainly can improve communication between providers and families and between different providers. What I don't think it can cure are things like homelessness. It can't really address severe poverty, and it really does not reduce adverse childhood experiences. Those require other types of interventions, some of the behavioral type interventions I think that Michael was referencing in his presentation. So that's where I'm going to stop. Next slide, please. I want to recognize all the different organizations that were involved in the work that I just presented to you. And Ed, I will ask that you not make the slides here downloadable. I'm fine if people want to come to your website and look at them, but much of this work is in press. The Minnesota study will come out in pediatrics shortly. The Washington State study is under review at a different journal. So because of that, we're embargoed, and I don't want to release the slides, if that's okay.
Sure.
Great.
Perfectly understandable. So there's a number of questions. I forward them to you. Can you read them, or do you want me to go through them?
Let me see if I can see them. Oh, it's in the chat, right? Yes.
It's under
questions. Audience questions. I don't see them.
Okay. I'll go through some. First one, given the high odds ratio demonstrated for child substance abuse and juvenile justice involvement, what are the implications of these findings in terms of treating foster child populations and juvenile justice populations and substance abuse exposed populations?
So I think those are obviously some of our highest risk children. And, Michael was talking about, wanting to really come up with a way to weight the different factors. And I think that the results that we have start to sort of give some picture about which ones you might want to weight more heavily. Again, if you are trying to allocate limited resources, I would say those children with those types of issues should be very high on the list of who would receive intervention.
Can you say something about the race of the populations in the two states?
So again, as Michael alluded to, we are in the Pacific Northwest. We are largely a non-Hispanic white population, probably around 75% of both of the populations fall into that category. The survey population, the 460 that we had, did have a higher representation of African-American families. There were 43% African-American families, which is higher than the overall population in that state. But the Washington State population only had 6% African-American, around 20% Hispanic population.
Did you provide any incentives to complete the survey in Minnesota?
We did not.
Okay. Someone asked, why were these two states selected for the studies?
So these were the two Medicaid agencies that were part of our center's consortium. So obviously Washington State I collaborate a lot with because I'm here, and then I had a collaborative relationship with the medical director for Minnesota Medicaid. So when we put in our grants for the center, he was they were one of our collaborating sites.
Okay. Under LEP, did you differentiate between ELL families and U.S.-born families who speak English as their only language, who have limited literacy skills? I'm not sure
So
if you followed that.
Yeah, the limited English proficiency variable in the Washington State study is tagged by family answers to the census question about not speaking English very well or not at all. And that's the same way it was done in the Minnesota administrative data, and we put that question in the parent survey. So we were trying to be consistent across the board there. So that's how that was determined.
Okay. Could social complexity include having a sibling with disabilities?
I would say yes. That is not something that we looked at, however.
Okay. Is the survey instrument you used in Minnesota available?
Yes, it is available. I would be happy to give that to you, Ed,
Okay.
and it could be distributed.
Great. So someone is asking why couldn't care coordinate? I think let me open this up now with Michael too, if you can make him available to speak, because we're getting a couple questions that cross over. One is neither of you mentioned specifically social workers or the role of hospital social workers. Any comment on that?
So I would say for the kinds of kids who were targeted, particularly in our Minnesota study, where the risk profile was not as severe as the risk profile we heard about from Michael, I would think an embedded social worker in the primary care medical home could really serve an important role in addressing the needs of the kinds of children that we were identifying in the Minnesota study.
Yeah, Michael?
I would echo that. We actually work very closely with our medical social workers that are embedded in our hospitals. We find them to be a huge, great source of information, as well as have long-standing relationships with these patients. They're just limited in their role in terms of being able to go into the communities and assist families with managing some of these challenging situations. So they're an integral part of what we do. We don't supplant any medical care, and we don't supplant any mental health care. We're kind of command central for the family in getting all the resources they need to properly care for their child's health.
Great. Can I pause here and ask, let's put up the next poll, which really speaks to Rita's presentation. Same two questions as we'd asked for Michael, if those listening in wouldn't mind filling these out for us. And the next one. Okay, so we're running out of time. The next slide shows some of the things that are on our foundation website, and so people are encouraged to go look at those, particularly Michael's vulnerability risk scale is there, as well as some relevant articles. And our website actually contains a lot of information on systems of care for kids with special health care needs. And the final slide for people who would like to contact the speakers gives the contact information for Dr. Rita Minigiano-Smith and Dr. Harris. And myself, if you need to contact me, and our foundation's website is at the bottom as well. So I thank the speakers. They were terrific. And thank all of you for listening in. This has been, I thought, a wonderfully informative presentation, and we're looking forward to doing more of these during the coming year. So thank you very much.